In corneal disorders, now we will discuss non-infective keratitis. It means the inflammation of cornea caused by non-infective causes. Okay, so we will discuss these conditions in details with their pathogenesis, clinical features, diagnosis and treatment. The first one is allergic keratitis and the second one is autoimmune keratitis. So what is allergic keratitis? Allergic keratitis is the inflammation of cornea caused by different types of allergies. We have two main subtypes of allergic keratitis: catarrhal marginal ulcer and polyclinical keratitis. Okay. So what is catarrhal marginal ulcer? Catarrhal marginal ulcer, it is the edema of peripheral cornea due to hypersensitivity reaction which ultimately leads to peripheral corneal ulcer. Okay. So first of all, there will be edema in the peripheral cornea due to hypersensitivity reaction. There will be edema and inflammation which ultimately leads to ulcer. This is called catarrhal marginal ulcer. What is the etiology? Etiology is that it is a type 3 hypersensitivity reaction to staphylococcal exotoxin or cell wall proteins or to both. Okay. So remember, in some books it has been mentioned as a type 1 and in some books it has been mentioned as a type 3, and in some books they are saying that it is the combination of both type 3 and type 1 hypersensitivity reaction to staphylococcal exotoxin and cell wall proteins. Okay, so this is the etiology. Now the pathogenesis. What is happening when there are the viral particles? Okay, when the staphylococcus inoculate the eye, so there will be the release of staphylococcal exotoxin and cell wall proteins. Okay, then what will happen? These staphylococcal exotoxin and cell wall proteins will activate type 3 hypersensitivity reaction and will cause the condition. For example, this is the corneal layer, so there will be the formation of immune complexes due to the antibodies and the staphylococcal antigens. So these immune complexes will deposit in the cornea and it will activate the complement system and immune system and will cause the edema and inflammation. Okay, so there will be edema and inflammation due to these immune complexes and activation of complement system. Okay, now this is the edema. Okay, and ultimately this edema will lead to peripheral corneal ulcer. Okay, so this is the pathogenesis of type 3 hypersensitivity reaction to staphylococcal exotoxin and cell wall proteins. Now, how the patient will present to us? The patient will present to us with, as I told you before in other lectures, okay, that remember there are some common clinical features for any corneal disease. So, these are pain, photophobia, blurred vision, lacrimation, redness, foreign body sensation and discharge. These clinical features will be present in every case of corneal disease, but they may be mild, moderate or severe and depends on the severity and duration of the corneal disease. Okay, so the patient will present to us with these clinical features, plus there is a special phenomena of this edema. There is a special phenomena. First of all, what is happening, that this edema develops in a special pattern. First it will appear at 2 o'clock position, then 4 o'clock, then 8 o'clock and then 10 o'clock. So this edema will form at 2, 4, 8 and 10 o'clock position, and ultimately these edema will coalesce together and will form large edematous areas. Okay, which will ultimately leads to the formation of ulcer. Okay, so remember there is one more thing, that there will be in catarrhal marginal ulcer we will have a clear gap between the limbus and the ulcer. There will be a clear gap. Okay, so there is a clear gap between the limbus and the ulcer. These are the clinical features for catarrhal marginal ulcer. The treatment is simple. As we know that it is a destructive condition due to the hypersensitivity reaction, so we will get steroids. And to remove the source of this autoimmune condition, we will get antibiotics as to remove the staphylococcal bacteria. Okay, and for the pain, we can use cycloplegics such as 1% atropine. Okay, so this was about the catarrhal marginal ulcer. Now the second allergic keratitis is pilectinular keratitis. Pilectinular keratitis is also a hypersensitivity reaction like the catarrhal marginal ulcer, but it is characterized by a localized nodule formation due to hypersensitivity reaction to the same antigen, to the staphylococcal exotoxin. Okay, so it is this hypersensitivity reaction to staphylococcal exotoxin, but it is type 4 hypersensitivity reaction. Okay, it is type 4 hypersensitivity reaction to staphylococcal exotoxin, and there will be the formation of nodule. Okay, there will be the formation of nodule at limbus, and this nodule will start spreading to the cornea. Okay, so this is a localized nodule which appears first at the limbus and then spread to the cornea. I have discussed this pilectinular keratitis in details with the lecture of pilectinular conjunctivitis. So you can go through that video and can learn more about this type of keratitis. Okay, so it will save us some time. Okay, so this was about the allergic keratitis. Now we will come to the autoimmune keratitis. Autoimmune keratitis means the inflammation of cornea caused by different types of autoimmune conditions. Okay, we have mainly three subtypes. We have the moron ulcer, we have the peripheral ulcerative keratitis, and interstitial keratitis. Okay, so what is moron ulcer? What is moron ulcer? Moron ulcer, it is a chronic, painful, progressive peripheral corneal ulcer due to autoimmune condition. Okay, so it is like catarrhal marginal ulcer. It is the peripheral corneal ulcer, but it is a chronic and very painful. Okay, etiology is that it is an autoimmune condition, but we do not know the exact source of autoimmunity. It is basically idiopathic. Okay, pathogenesis is that what will happen, we know that there is the limbal vasculature. Okay, there is the limbal vasculature, and this limbus depends on this, as we know that the cornea is a vascular structure. Basically, interiorly it is supplied by tears and posteriorly by aqueous humor, but the limbal area is supplied by this limbal vasculature. Okay, so what is happening in the pathogenesis is that, first of all, as there will be the deposition of immune complexes will deposit in this limbal vasculature, and it will cause limbal vasculitis. So I told you before that the exact source of these immune complexes, we do not know what is the exact source. It is mainly idiopathic. So these immune complexes, they will start with inflammation of this limbal vasculature called limbal vasculitis. So when there is the limbal vasculitis, we know that this area is now ischemic. This area is now ischemic. The blood supply has been stopped to the limbus because of the limbal vasculitis. So there will be the ischemic necrosis. The ischemic necrosis will start in the limbus. Okay, due to the limbal vasculitis. This is the pathogenesis of moron ulcer. Now, how the patient will present to us? The patient will present to us, it has mainly two forms. The first one is benign, which is unilateral and mainly presenting in old adults. And the second one is the bilateral and progressive and painful, which is presenting in young adults. Okay, so the ulcer is following a special behavior. The ulcer is moving to the center of the cornea as well as circumferentially to the periphery. Okay, so the ulcer is spreading in this manner, circumferentially as well as central. And as the ulcer is progressing at the advancing age, if this is the advancing age of the ulcer, okay, there is an overhanging ridge like this. There is an overhanging ridge, and the ulcer is it look like it is digging into the cornea, okay? So at the advancing edge of the ulcer, there will be an overhanging ridge. But remember, before moving forward to other clinical features, you should know that these common clinical features, they are present in every corneal disease, as I am telling you again and again. Pain, photophobia, blurred vision, lacrimation, redness, foreign body sensation and discharge. But that depends on the severity of infection. Okay, as the pain is very severe in the moron ulcer, and it is not so much severe in the catarrhal marginal ulcer. Okay, so I told you that there are two forms. Now the ulcer is following a special behavior, moving in a periphery, moving circumferentially as well as centrally. And there at the advancing edge there is an overhanging ridge. Okay, the area which has been left behind is now healed. Okay, it is a healed cornea, but it is only consists of a descent membrane which has now been covered by blood vessels and the conjunctival epithelium. So the conjunctival epithelium will now cover the bare area of descent membrane, and it will heal the area. But now it is a thin healed cornea, which is only consisting of a single layer of descent membrane. Okay, and it is also showing that why the ulcer is spreading circumferentially and centrally. As the new vasculature is forming, it will also, the autoimmunity will also causes the vasculitis of this vasculature, and it will further damage the onward area. So it is spreading due to the formation of new vasculature and the autoimmune activation. Okay. So these were the clinical features of the moron ulcer. Okay. The treatment. How can we treat the condition? The treatment, as the ulcer is chronic, painful, progressive, and even it can be a side-threatening condition. So we should start the treatment with steroids. Okay, and steroids are given very frequently. They are saying that we can even give steroid 1 hourly. At every hour, after every 1 hour, we will give steroid. Okay, so steroid will be given initially very frequently. Then we can also give in immunosuppression called cyclosporin. Okay, but its effects are late, so cyclosporin can be given. If this ulcer is not responding to cyclosporin and steroids, then alternative drugs are, for example, we can use interferon alpha 2 can be given. Okay, interferon alpha 2 can be given if the ulcer is not responding to these drugs. Okay, and for treating secondary bacterial condition, we will give antibiotics, and for pain we can give cycloplegics. Okay, so this is the treatment of the moron ulcer.